Welcome to the Living Hell podcast. I'm your host, Jo Doyle. In this episode, we'll hear from Dr. Karolina Afors, who is a gynaecologist with over 17 years of experience in the NHS. She specialises in pelvic pain and endometriosis and even operates on endometriosis patients. She teaches regularly at the Royal College of Obstetricians and Gynaecologists and holds a senior committee position within the British Society of Gynecological Endoscopy. She also contributes to the Pelvic Pain Special Interest Group of the European Society for Gynecological Endoscopy. Beyond her clinical practice, Dr. Afors plays a leading role in women's health innovation. We're here with Dr. Karolina Afors. I'm really excited to talk to you today because it seems like it's a hot topic at the moment. There's a lot of information online, a lot of misinformation online. It feels like a lot of women are telling their stories, many of them horrific, experiences. So it's exciting to hear from you a bit more of the stats, the facts, expert point of view. We're starting with a question for every episode. How did you sleep last night, truthfully?
I'm not a great sleeper. I've got two little people who come into my bed every single night. And I think I doom scroll a little bit too much because that's my time out to do it. But sleep is actually very important. So for endometriosis, for chronic diseases, so my intention is to do better at sleeping.
Yeah, good. Okay, can you just tell me really quickly a bit about you and what you do?
So I'm Karolina, I'm a consultant gynaecologist and I've specialised in endometriosis and pelvic pain. And what that means is that I do a lot of surgery for endometriosis, but I am perhaps a little bit different to some of my counterparts in also being very specialist in pelvic pain and how to manage the whole person as they go through this journey, through the different life stages, because it is a chronic disease. And that might be lifestyle measures as well as holistic options, as well as medical, as well as surgical. So I like to look at it as a human approach, let's say, to managing their endometriosis and pelvic pain.
Can you just tell us straight off, what is endometriosis?
So endometriosis is a condition where endometrial-like tissue, which line the inside of the uterus, get deposited outside. So this could be in the pelvis, but it could also be outside the pelvis, so on the diaphragm, elsewhere on the bowel, for example. We don't really know what causes endometriosis. It's probably multifactorial, so there's a genetic aspect to it, an autoimmune aspect to it. And this is why it makes it quite complex to treat. Unfortunately, there is no cure for endometriosis, which makes it even more challenging, certainly for us as clinicians.
And how soon can you see the first signs of endometriosis? And does it get better or worse with age?
It's a really difficult question to answer because endometriosis, it's a heterogeneous disorder. So when I say heterogeneous, I mean that it varies very much from one person to the next. So you might have really severe disease, but minimal symptoms and vice versa. So essentially, disease severity doesn't always correlate to symptoms. And sometimes you can get superficial disease or more deep disease, which you perhaps treat differently. So sometimes we put these all together, and that's largely because there's been a lack of research in the space. And that's why you just got to listen to your patients. And ultimately, there's no such thing as it's just a period or it's in your head. And if you are having painful periods, and what I ask my patients is, if it's a painful period that's impacting on your quality of life, on your ability to do day-to-day activities, then it's something that needs to be investigated. And
what's the difference between endo and adenomyosis?
So adenomyosis is something that's tends to be diagnosed a bit later on. And so in terms of age-wise, but essentially you get endometriosis-like tissue deposited within the muscular wall of the uterus. And it typically causes very heavy, painful periods. It's interesting that 50% of women with adenomyosis will also have endometriosis. And I think lots of people don't quite understand that or appreciate that. So if there is one, you should also be thinking of or looking for the other. And that's always been something for me that I've noticed.
So you spoke about it a little bit then, but what are the different stages?
So there are actually different staging criteria, different classifications. We typically use stage 1 to 4. So stage 1 is more superficial disease and Stage 4 would be deeper disease, more than 5 millimetres, that's infiltrating below the surface of the peritoneum. So the peritoneum is, imagine your body organs are covered in like a curtain, so it's deep to that layer. And it can then involve different organ systems. So that initially is organs within the pelvis, but then if it's outside the pelvis, such as the bladder, the bowel, then you're talking more stage 4 disease. The problem is that stage 1 to 4, that loosely isn't very helpful. And it's really important to have a classification system that allows us as surgeons to all speak the same language. So there are other classifications like the Enzian classification, which is where they are much more prescriptive, so looking at the size of the nodule, exactly where the nodule or the endometriosis is. And this allows us to compare like with like in terms of both research so that we can improve patient care. And I suspect that this will be something that replaces potentially this more arbitrary stage 1 to 4 classification.
What are the myths that you see around endo? Because obviously, like I said, there's lots of information online, everyone's sharing their story.
Gosh, there's so many. You're too young to get endometriosis, so you can get endometriosis at any age, and I see lots of adolescents, unfortunately, who do have endometriosis. Pregnancy is the cure for endometriosis, so it's not the cure for endometriosis, it's just that pregnancy is a bit like being on a contraceptive. You've got your periods are suppressed, so you potentially don't get the same volume of symptoms, but obviously everybody's journey is different. And also this idea that endometriosis stops when you go through the menopause. Not necessarily. The risk of recurrence of endometriosis in menopause is far less, probably affects about 4 to 8% of people, but it can still occur. And I think that's it for time being.
Some women talk about the delay that they experience when it comes to diagnosing their endo. Is that something that you see with your patients? Why do you think that delay occurs?
The problem is with endometriosis, and actually anything in your tummy area, is that there are lots of different organs. So you might end up getting referred, or the channel by which you access care might be a gastroenterologist rather than a gynaecologist, for example. So, on average, endometriosis takes 7 years to be diagnosed. In my experience, it's been 10 years. I've seen some patients who's been up to 14 or 15 years, unfortunately. And I think because with every chronic condition where there are lots of different symptoms, there's not a diagnostic test either. It makes it really challenging to diagnose it. And until fairly recently, nobody knew what endometriosis was. They could barely say the word, let alone actually understand it. Thankfully, there's been a lot more awareness about it, which I'm really happy to see. But those are just a few of the challenges when it comes to endometriosis diagnosis.
How close do you think we are to a test?
So there is a saliva test, for example, which it's actually available, but it needs to be validated a little bit more. There is also another test. They're actually using it for cervical cancer, where you take a swab. But there has been some suggestion that similarly, you could use a similar test like that actually to test for endometriosis. And there is also some people that are looking at screening of our menstrual blood, and that might be useful to detect, for example, endometriosis. So there are definitely ways forward. For me, though, the treatment, you're still going to initiate treatment anyway if they're in pain or if they've got symptoms that are impacting on their quality of life. So I think it is very important to have a diagnostic test, and hopefully that will be in development and on the market much more readily available. But nowadays also we've got ultrasound scan and MRI. Whilst this can miss endometriosis, particularly in more superficial disease, we are getting much better at picking up endometriosis on imaging. And I suspect in the future there's going to be more AI use detection of reading out MRI reports or reading the pictures from MRI, which will allow us to validate diagnosis of endometriosis a lot more.
You touched on it before when you talked about your interest in holistic methods as well. When it comes to treating or managing endo, what are some things that you recommend your patients?
So there's no cure for endometriosis. And one of the huge misconceptions is that surgery is a cure for endometriosis. It's not. So if you don't have a cure, you need to understand, how do I live with this? Or how do I improve my quality of life? How do I manage it as best as I can? And in order to do that, you need to have a holistic approach. So for me, that's looking at diet, and equally, I don't want you to be really restrictive in your diet options, but trying to find out what works for you. So some of the evidence suggests reducing red meat, increasing things like omega-3. For bloating, peppermint tea or chewing gum, ginger tea can actually be really helpful for painful periods. And then also looking at pelvic floor physio, but also general physiotherapy, because when you're in pain all the time, you hold yourself differently. You might get hypertrophy, like overactivity of certain muscle groups. So you almost need to know how to relax it. And I think we should always look to other more holistic treatment options. So whether that's acupuncture, if that works and if that makes you feel better, I think that's equally as important, and not just going straight to surgery. And even with surgery, because it's not curative, these can be done all alongside. So I'm all for having a holistic approach that you can do alongside more conventional treatment options that I also prescribe. But ultimately, if those holistic options make you feel better, then that's even better for you, for the patient.
So I can imagine that it's quite scary to learn that you have endo. What would you say to the women that may think they have it or have just been diagnosed with it, in terms of next steps and how they can get that support?
So I think the biggest challenge I've ever had is talking to young girls, so let's say adolescents, about endometriosis, because they're afraid, they're scared. Sometimes this has been diagnosed before they're even sexually active. So maybe they've just started having their periods, for example. And you're having to have these difficult conversations, or you want to give them a full explanation. And you do need to talk about the impact that it can have on fertility, for example. And if I imagine even saying that to my adolescent self, that was by no means ready to have children at that point, but to talk about the future, about the possibility of having children, how this might be potentially impacted or may not be, it can be quite challenging. So sometimes for me, what I do is I give them as much information. I realise that in the first consultation, probably about half of it sinks in. And this is another thing about endometriosis, and for that matter, any chronic condition, is that they should be seen regularly to monitor their symptoms, to also educate them about, as women go through different life stages, as you perhaps then if you're having then sexual intercourse, or if you're then thinking about children, or if you're in the perimenopausal stage, how you manage that condition is going to change. So that's why it's important to have a connection with a healthcare practitioner or a service where you can check in with them and understand what's okay, what are some warning signs, what are things that perhaps we need to investigate further.
Can endo show up at any point in your life, or do you always typically see it when women are younger?
No, it can show up at any point in their lives. Probably because some women may have not had any symptoms for a long time. And then perhaps for whatever reason, there's been a trigger for that to come to the forefront.
How do you think hormonal contraception can play a part in managing symptoms?
I think I'm probably going to say something that's not very popular, but hormonal contraception has been around for a really long time. It is a safe drug. We've had it since the 1950s. And if you look at novel drug treatments, we're going to have far more evidence about the hormonal contraceptive pill than we will any new drug that comes into play. So for me, the contraceptive pill, it doesn't cure it either, but if it helps patients or women to live a better quality of life, to get on with their day-to-day activities, to be able to work, go to university, whatever it is, I think that's really, really important. For me, the great disappointment about contraception is the lack of innovation in the space. So there has been some, and we've actually, I say the lack of innovation, but in the last year there has been a lot more drug development in terms of drugs coming to market in the contraceptive or hormonal space for endometriosis. But historically, they just changed a small part of the progesterone molecule to then have a new drug that they could then license and obviously increase the patent for that drug. But it is changing, and I think also this understanding that women can have side effects in response to hormonal treatment. And I thank patients for actually bringing that to our attention so that we can then say, okay, this hasn't worked for you, but then let's think of something else. And the good thing about hormonal treatment is that there are lots of different options to help manage your treatment. And I think for me, the most important thing is also having an insight into that. And hopefully there'll be diagnostic tests in the future that would say you will respond better to this one for these reasons. And that would certainly help me in managing patients better.
Do you think your patients, when you may suggest it, that they're very anti it? Is that what you have seen?
So it very much depends on the individual. Sometimes it's a journey and it isn't for everyone. Obviously, if somebody's wishing to conceive, it's not the right option. If some people have really had bad side effects, and whether that's impacted on their libido, their mental state, my job's to support them and give them the options. But that's the whole point. It's about shared decision making. So the idea of shared decision making is that we come up with this or we come up with a plan together. But also it's you, the individual, who makes the decision. And I'm never going to push you down a decision that I think I can just provide you with guidance.
When looking at pregnancy and after pregnancy, have you seen your patients feel better after pregnancy? As you say, it's not a cure, but it can help. Or is that a bigger myth than we think?
I think it depends. So I have had some women when they've been breastfeeding for a long time after the pregnancy that actually their endometriosis has improved. And again, I think that's an area that we probably don't understand quite as much about. I think it varies differently. And this is the whole idea that for me, we group endometriosis, we consider it as a single condition. But for me, it's actually such a heterogeneous condition that it's probably multiple conditions under one umbrella. So we're not comparing like with like. So I think that perhaps more severe disease is less likely to get better after pregnancy. Perhaps more superficial disease. And when I say superficial, I've always got to be careful the language I use. I'm not trying to invalidate the endometriosis that individual has. I'm just trying to differentiate one aspect, so deep from superficial. And I guess this superficial stage 1 disease it's actually sometimes harder to treat from my perspective because in my experience tends to respond not as well to surgery or higher chance of recurrence. So then you're looking at more medical management options.
When looking at the symptoms women are facing, a lot of women have painful periods. It's hard to know what's normal and what's not normal. And what kind of questions should they be asking their GP or expert?
I think if they're having painful periods that are severe enough to not improve with simple painkillers, that it's impacting on their quality of life, that is stopping them being able to go to school, go to work, have relationships, impacting their friendships, for example, then I think they should seek help. And the way they advocate for themselves is to talk about the options, to ask for an ultrasound scan, to ask about what the treatment options are, to mention the word endometriosis and discuss it openly with your GP, for example. And then if things aren't helping, then to ask for a referral to a specialist unit. And I do think the GPs are much more familiar with endometriosis. They're much more aware of the referral pathways. And they do understand that investigating it by means of an ultrasound scan or MRI is feasible. So I do think that it's going in the right direction. I just think that we have limited resources, unfortunately.
I was reading a report today that linked vaping to perhaps infertility, very emerging research. Have you seen endo being linked to, in your patients, other lifestyle behaviours in your experience, or is there research around other things that perhaps Gen Z are more trending with?
The problem is with endometriosis is there are links with lots of different things. But one of the main thing, which I don't know if it's so relevant for Gen Z, but it would be in the future, is if you've got endometriosis, you've got a higher risk of developing preeclampsia, pregnancy complications, perhaps where the baby doesn't grow as well. Also, you're more likely to perhaps potentially need a cesarean section, or if you've got adenomyosis or endometriosis, more likely to have a bleed after pregnancy. There's also emerging research, which I think is really important, that is just not in the public domain to the same extent, is the risk of cardiovascular disease in women. It's actually the biggest cause of death for women globally, but also there is a link between endometriosis, adenomyosis, and being at a higher risk of developing cardiovascular disease and stroke. And I think it's a missed opportunity not to have a regular check, for example, like you have in diabetes, a once a year annual review where you ask about your endometriosis symptoms, you take a blood pressure, a pulse, you have that opportunity to check for other things as well, and perhaps also ask them about and also investigate fertility, for example. And I think these are some nuances that isn't well integrated into our care model, specifically in the UK.
So, not to deter anyone from the medical interventions that are necessary, but just looking back on the holistic side of things, have you seen a patient who has been able to turn around their endo quite significantly with simple things like diets or supplements or holistic living? Like, is that possible to manage it in that way?
Yes, and I'll say something even more controversial. You can get chronic pelvic pain can coexist with endometriosis. So endometriosis may be the trigger. So it's a biochemical, or you've got an abnormality that's causing the pain. But then the pain can self-perpetuate. And what you can do is, we don't have pain receptors, but it's our brain who centrally sends a signal to say that's painful and to then recommend something like walk away, or a warning sign to say not to ignore it. And sometimes what happens where endometriosis is the initial trigger is that you get this, what we call neuroplastic pain, which is something quite new that was only really coined in 2018, that you can then start to have pain appear in different areas over your whole body, for example, in different areas that may not be related to where you had your previous endometriosis surgery or your previous endometriosis deposit. And that's because you get upregulation of nerve fibers, of neurotransmitters, and all of these things can also be affected by stress, anxiety, the day-to-day living of being with a chronic condition. And what I've seen in my patients and what I've learned a lot is it's really important to have holistic, and stress and anxiety in any chronic condition. If you're able to manage that, it will not make it go away, but it will improve your symptoms. And this is something that we don't talk about enough as doctors, but it's probably why surgery is not a cure. And unfortunately, 20% of women will have a recurrence of their endometriosis 2 years after endometriosis, and 50% is after about 5 years. So we need to be looking and understanding that there's also this aspect of central processing of pain along with endometriosis, and treating the two at the same time. So it's not in your head, but there's an aspect of your brain being involved in how you perceive pain. And if we don't treat the two of those things together, we're never going to have a formal, all-human approach to treating this condition.
We've seen some innovations within the sort of period blood space using those biomarkers to diagnose. How hopeful are you about those innovations when it comes to endometriosis or any sort of gynecological condition?
I'm really hopeful. I think there's also going to be a lot of development in this space in terms of epigenetics as well. So it'll be biomarkers, epigenetics, but also looking at not only surgical treatments. There's other where you've got brain stimulation, for example. So they've got these cradle type devices you can put on your head, which is meant to improve both mood associated with PMS and PMDD, but also pain associated with pelvic pain and endometriosis. And it'd be really nice to see even more development in that space. And then also still looking at that whole female human approach to managing endometriosis. So across different life stages, your needs will change, and tailoring it according to what that specific need is of that individual, I think is really important.
Other than, of course, the work that you do, what kind of resources are out there for women? Like I said, there's lots of misinformation. Where would you direct your patients to?
So I think Endometriosis UK has got a wealth of research out there. I think there's also the NCPOD survey, which is a survey that came out from patients and doctors about endometriosis. And then there's also the APPG. It's a couple of years old now, about endometriosis, which is the all-parliamentary group document about endometriosis. And I think those are all really useful documents. The NCPOD one, I read all the time, and what I like about it is that it puts quotes of the testimonials from patients. And those are what I always read. They're normally like a small caption. They've obviously been slightly edited out, but it really, there are similar themes that you see throughout it. And that always highlights to me the needs of where we need to focus our care and attention.
A final question here. What would be one piece of advice that you would give to a listener who might be struggling with endo?
Don't suffer in silence. Endometriosis affects 1 in 10 women. That's 180 million women worldwide. There are support groups and there are people out there. Some people are scared of going to see a doctor or a healthcare practitioner, but then that's when you should rely on perhaps support groups to help answer questions, and then perhaps that builds up your confidence to go and see someone else. But don't suffer in silence. It's not in your head. And if doctors, we don't always listen as we should. And if we're not listening, just make yourself be heard. And that sometimes means advocating for yourself. And even if you look at the data, it's over 58% of women will have seen their GP multiple times. And whilst I'd like to see an improvement in that, we are all human and we do make mistakes as doctors. We are listening, and it's our job to listen.
Awesome. Thank you so much. I feel like we've covered quite a bit. You might be getting lots of questions sent your way. We'll make sure that people know where to find you and find more information. But thank you so much for joining.
Thanks very much.
Thank you so much for listening and watching to the Living Health Podcast. If you are suffering with the same condition or you know someone who is, I hope you have practical information that you can take away or relate to some of the things that we've spoken about on this episode. We are always after feedback or recommendations, so please leave your thoughts or let us know who you'd like us to interview next.